Welcome back, YouTubers, to my channel of an everyday life of an Aspie. If you're new to my channel, I'm Aspie. I welcome you all. I'm all about creating mental health and awareness and sharing my life stories with Aspergers Syndrome and the like. If you're into one of these, feel free to follow me on my journey by, subscribing on the bottom right hand corner of the screen. No pressure there. Also, while you're down there, turn on the notification bell. In this point of time, I'm trying to do as many of the mental health disorders and other health related disorders that's not mental health but other disorders that will come into play of what we may need to know about of certain conditions that may be brand new to us, and I'm hoping to educate you all regardless what it may be, so hopefully we'll learn something along the way. I'm hoping also within saying this that with what I've shared with you all based on whatever I'm sharing, be it if it's from my journal excerpts or whatever from my past life, seeing what my life was like in the past before being diagnosed with Aspergers Syndrome, and just with some everyday things I went through in my past life that will be coming to play with you also, that hopefully it can be of lightenment for you. So this one's all about conduct disorders, and I'm hoping that you're liking these. Smash the like button if you are, or the comment below for letting me know, because as I said, it's really good to see that kind of connection that we can have. So the very first question, as always, when it comes down to many of these mental health disorders or any other form of disorders, is what is conduct disorder? Conduct disorder is a mental disorder that is diagnosed in childhood or in the adolescent's life that presents itself through a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate norms has been violated. These behaviors are often referred to as antisocial behaviors. As I shared, there is one based on antisocial disorder or what have you, which I'll link it in the I bar above me on the right hand corner of the screen, or even in the description if you want to find out more of what I'm talking about. Conduct disorder, however, is a serious behavioral and emotional disorder that occurs in teenagers and children. A child with this disorder may display a pattern of disruptive and violent behaviors and have problems following certain set rules. It's not common for children and teens to have behavior-related problems at some time during their development. However, the behavior is considered to be a conduct disorder when it is long-lasting and when it violates the rights of others, goes against accepted norms of behavior, and disrupts the child's or family's everyday life. It's often seen as a precursor to antisocial personality disorder, which is per definition not diagnosed until the individual is at least at the age of 18 years old. Just a key note here, this disorder shouldn't be confused with disorderly conduct whatsoever. And also, as another keynote, as a disclaimer, I'm not a doctor. I'm just your normal everyday Joe blog sharing my life stories with Aspergers Syndrome and the like. And if you see any of the warning signs and symptoms of what I'm sharing with you, albeit on these mental health disorders or any other conditions, seek professional help for yourself or your loved one, or seek an opinion for yourself or loved one, because I don't forever condone self-harm. So let's continue this. So the next one you may to look out for is the symptoms of this disorder. Symptoms of conduct disorder again will vary depending on the age of the child and whether the disorder is mild, moderate, or severe. And the general symptoms of conduct disorder, however, they fall into 4 general categories, which are 1. Aggressive behaviors. These behaviors are the ones that are threatening or cause physical harm and may include fighting, bullying, being cruel to others or animals, using weapons, and forcing another into sexual activity. 2. Destructive behaviors. This will involve basically intentional destruction of property such as arson, deliberately setting fires, and vandalism, harming others' persons' properties. Deceitful behaviors is number 3. This may include repeated lying, shoplifting, or breaking into homes or cars in order to steal. Last but not least is the violation of rules, number 4. This will involve going against accepted rules of society or engaging in behavior that's not appropriate for the person's age. These behaviors may include running away or skipping school, playing pranks, or being sexually active at a very young age. In addition, many children with conduct disorder are irritable, have low self-esteem, and may tend to throw frequent temper tantrums. Some may abuse drugs and alcohol. Children with conduct disorder often are unable to appreciate how their behavior can hurt others and generally have little guilt or remorse about hurting others. One of the symptoms of conduct disorder is a lower level fear. Research performed on the impact of toddlers exposed to fear and distress shows that the negative emotionally therapeutic toddlers, empathy-related response to distress. The findings support that if a caregiver is able to respond to infant cues, the toddler has a better ability to respond to fear and distress. If a child doesn't learn how to handle fear or distress, the child will be more likely to lash out onto other children. If the caregiver is able to provide therapeutic intervention, teaching children at risk better empathy skills, the child will have a lower incident level of conduct disorder at a later stage in life. Developmental cause. Currently, 2 possible development causes are thought to be linked to this disorder. The first one is known as the child onset type and occurs when conduct disorder symptoms are present before the age of 10 years. This cause is often linked to a more persistent life course and more pervasive behaviors. Specifically, children in this group have greater levels of ADHD-like symptoms, neuropsychological defects, more academic problems, increased family dysfunction, and higher likelihood of aggression and violence. There is debate among professionals, however, regarding the validity and appropriateness of diagnosing young children with conduct disorder. The characteristics of diagnosis are commonly seen in young children who are referred to mental health professionals. A premature diagnosis made in young children and thus labeling an individual may be inappropriate. It is also argued that some children may not in fact have conduct disorder but are engaging in developmentally appropriate disruptive behaviors. And in the second developmental cause that is known as obviously as to this stage is the adolescent onset type. This one occurs when conduct disorders symptoms are present at the age of 10 years. Individuals with adolescent onset conduct disorder exhibits less impairment than those with the childhood onset type and aren't characterized by similar psychopathology, however. At times, these individuals were met with their deviant patterns before adulthood. Research has shown that there's a great number of children with adolescent onset conduct disorder than those with the child onset, suggesting that adolescent onset conduct disorder is an exaggeration of developmental behaviors that are typically seen in adolescents, such as rebellion against authority figures and rejection of conventional values. However, this argument isn't as fully established, and empirical research suggests that these subgroups aren't valid as it once was thought. In addition to these 2 causes that are recognized by the DSM-5 or 4, these appears to be a relationship among a personal defiant disorder, conduct disorder with antisocial personality disorder. Specifically, research has demonstrated continuity in the disorder such that conduct disorder is often diagnosed in children who have previously been diagnosed with ODD. And most adults with antisocial personality disorder were previously diagnosed with conduct disorder. For example, some research has shown that 90% of children diagnosed with conduct disorder had a previous diagnosis of oppositional defiant disorder. Moreover, both disorders share relevant risk factors and disruptive behaviors, suggesting that oppositional defiant disorder is a development precursor and milder variant of conduct disorder. However, this isn't to say that this is trajectory occurring in all individuals. In fact, about only 25% of children with ODD will receive a later diagnosis of conduct disorder. Correspondingly, there is an established link between conduct disorder and the diagnosis of antisocial personality disorder as an adult. In fact, also, in the current diagnostic criteria for antisocial personality disorder that has been required are conduct disorder diagnosis before the age of 15. However, again, 25 to 40% of youth with conduct disorder will develop antisocial personality disorder. Nonetheless, however, many of the individuals who do not meet this full criteria for antisocial personality disorder will still exhibit a pattern or sign of social and personal impairments or antisocial behaviors. These developmental trajectories suggest the existence of antisocial pathways in certain individuals which have important implications for both research and treatment. Associated conditions. Children with conduct disorder have a high risk of developing other adjustment problems, as shared previously. Specifically, risk factors associated with conduct disorder and the effects of conduct disorder symptomatologically on a child's psychosocial context have been linked to overlap with other psychological disorders. In this way, there seems to be reciprocal effects of comorbidity with certain disorders, leading to certain or increased overall risk for these youth. ADHD is the condition that is most likely common associated with this disorder, with approximately 25 to 30% of boys and 50 to 50% of girls with conduct disorder having a comorbid ADHD diagnosis. While, however, it is unlikely that ADHD alone is a risk factor for developing conduct disorder. Children who exhibit hyperactivity and impulsivity, along with aggression, is associated with the early onset of conduct problems. Moreover, children with comorbid conduct disorder and ADHD show more severe aggression. Substance use disorders. Conduct disorder is usually highly associated with both substance use and abuse. Children with conduct disorder have an earlier onset of substance abuse as compared to their peers, and also tend to use multiple substances. However, substance use disorders themselves can directly or indirectly cause conduct disorder-like traits in about half of the adolescents who have substance use disorder. As mentioned before, it seems that there is a transactional relationship between substance use and conduct problems, such as that aggressive behaviors increase substance abuse or substance use, which then leads to this aggressive behavior. Substance use and conduct disorder can lead to antisocial behavior in adulthood. Causes of conduct disorder. The exact cause of conduct disorder, obviously, as many other disorders, can be unknown, but it is believed that a combination of biological, genetic, environmental, psychological, and social factors does play a key role here. The biological side of it, some studies suggest that defects or injuries, shall I say, to certain areas of the brain can lead to behavior disorders. Conduct disorder has been linked to particular brain regions involved in regulating behavior, impulse control, and emotion. Conduct disorder symptoms may occur if nerve cell circuits along these brain regions don't work properly. Furthermore, many children and teens with conduct disorder also have other mental illnesses such as ADHD, learning disorders, depression, substance abuse, or an anxiety disorder, which may then contribute to the symptoms of conduct disorder. Genetics. Many children and teens with conduct disorder have close family members with mental illnesses, including these mood disorders, anxiety disorders, substance use disorders, and personality disorders. This may suggest that a vulnerability to conduct disorders may be at least partially inherited. Environmental. Factors such as dysfunctional family life, childhood abuse, traumatic experiences, a family history of substance abuse, and inconsistent discipline by parents may contribute to the development of conduct disorder. Psychological. Some experts believe that conduct disorders can reflect some problems with moral awareness, notably lack of guilt and remorse and deficits in cognitive processing. Social. Low socioeconomic status and not being accepted by their peers appear to be risk factors for the development of conduct disorder. While the cause of conduct disorder is complicated by an intricate interplay of biological and environmental factors, however, identifying the underlying mechanisms is crucial for obtaining accurate assessment and implementing effective treatment like many other disorders. These mechanisms serve as the fundamental building blocks on which evidence-based treatments are developed. Despite the complexity, several domains have been implicated in the development of conduct disorder, including cognitive variables, neurological factors, intra-individual factors, familial and peer influences, and wider contextual factors. These factors may also vary based on the age of onset, with different variables related to early, e.g. neurodevelopmental basis, and adolescent, e.g. social peer relationships onset. The risks. The development of conduct disorder isn't immutable or predetermined. A number of interactive risk and protective risk factors exist and can influence and change outcomes. And in most cases, conduct disorders will develop due to the interaction and gradual accumulation of risk factors. In addition to the risk factors identified under cause, several other variables place youth at increased risk for developing the disorder, including child physical abuse and prenatal alcohol abuse and maternal smoking during pregnancy. Protective factors have also been identified, and most notably includes the high IQ being female, positive social orientations, good coping skills, and supportive family and community relationships. However, mere correlation between a particular aspect and a later developmental outcome, such as a conduct disorder, cannot be taken as a definitive evidence for the causal link. Learning disabilities. While language impairments are most common, approximately 20 to 25% of youth with a conduct disorder have some type of learning disability. Although the relationship between the disorders is complex, it seems as if learning disabilities result from a combination of ADHD, a history of academic difficulty and failure, and long-standing socialization difficulties with family and peers. However, confounding variables such as language deficits, SES disadvantage, or neurodevelopmental delay also may be needed to be considered in this relationship, as they could explain some of the association between conduct disorders and learning problems. Cognitive factors. In terms of cognitive function, intelligence and cognitive defects are common amongst youth with conduct disorder, particularly with those with the early onset and have intelligent quotients or IQ, one standard deviation below the mean, and severe deficits in verbal reasoning and executive function. Executive function difficulties may manifest in terms of one's ability to shift between task plan as well, and also inhibit a proportionate response. These findings hold true even after taking into account other variables such as socioeconomic status and education. However, IQ and executive function deficits are only one piece of the puzzle, and the magnitude of the influence is increased during transactional processes with environmental factors. Brain differences. Beyond difficulties in executive function, neurological research on youth with conduct disorder also demonstrate differences in brain anatomy and function that relates to the behaviors and mental anomalies associated in conduct disorders. Compared to normal controls, youth with early and adolescent onset of conduct disorder displayed reduced responses in brain regions associated with social behavior, i.e., amygdala, ventromedial prefrontal cortex, insular inferior cortex. In addition, youth with conduct disorder also demonstrated less responsiveness in the orbitofrontal regions of the brain during a stimulus reinforcement and reward task. This provides a neural explanation why youth with conduct disorder may be more likely to repeat poor decision-making patterns. Lastly, youth with conduct disorder displays a reduction in grey matter volume in the amygdala, which may account for the fear conditioning deficits. This reduction has been linked to difficulty processing social and emotional stimuli regardless of the age on the onset. Aside from the differences in neuroanatomy and activation patterns between youth with conduct disorder and controls, neurochemical profiles also may vary between these groups. Individuals with conduct disorder are characterized as having reduced serotonin and cortisol levels, e.g., reduced hypothalamic pituitary adrenal axis, as well as reduced autonomic nervous system functioning. These reductions are associated with the ability to regulate mood, impulsive behaviors, weakened signals, and anxiety and fear, decreased self-esteem. Taken together, these findings may account for some of the variants in the psychological with the youth conduct disorder. Intra-individual factors. Aside from findings related to neurological and neurochemical profiles of youth with conduct disorder, intra-individual factors such as genetics may also be relevant. Having a sibling or parent with conduct disorder increases the likelihood of having no disorder with a heritability rate of 0.353. There also tends to be a stronger genetic link for individuals with childhood onset compared to adolescent onset. In addition, youth with conduct disorder also exhibit polymorphism in the monoamine oxidase aging, low resting heart rates, and increased testosterone. Family peer influences. Elements of the family and social environment also play a key role in the development and maintenance of the conduct disorder. For instance, antisocial behavior suggests of conduct disorder is associated with single-parent status, parental divorce, large family size, and young age of mothers. However, these factors are difficult to tease apart from any other demographic variables that are known to be linked with conduct disorder, including the poverty and low socioeconomic status. Family functioning and parent-child interactions also play a parental substantial role in childhood aggression and conduct disorder, with loss of parental involvement and inadequate supervision and unpredictable discipline practices. Reinforcing youth's defiant behaviors, peer influences have also been related to the development of antisocial behavior in youth particularly peer rejection in childhood and association with deviant peers. Peer rejection is not only a marker of the number of externalizing disorders, but also a contributing factor for the continuity of the disorders over time. Henshaw and Lee of the research paper in 2003 also explains that association with deviant peers have been thought to influence the development of conduct disorder in 2 ways. 1, selection process whereby the youth with aggressive characters choose deviant friends, and 2, a facilitation process whereby deviant peer networks bolster patterns of antisocial behavior, and especially by bullying and colleagues. Parenting programs were shown to possibly affect child behaviors and reduce costs to the public sectors. How is conduct disorder diagnosed? Conduct disorder is classified in the 4th edition of the Diagnostic and Statistical Manual of Disorders. It is diagnosed based on a prolonged pattern of antisocial behavior, such as serious violation of laws and social norms and rules in people younger than the age of 18. Similar criteria are also used in those over the age of 18 for the diagnosis of the antisocial personality disorder. However, no proposed revisions for the main criteria of conduct disorder exist in the DSM-5. However, there is a recommendation by the group to add an additional specifier for callous and emotional traits. According to these 5 criteria for conduct disorder, there are 4 categories that could be present under child's behavior: aggression to people and animals, destruction of property, deceitfulness or theft, and serious violation of rules. Almost all adolescents have a substance use disorder have conduct disorder-like traits, but after successful treatment of the substance use disorder, about half of these adolescents will no longer display these counterparts of these symptoms. Therefore, it's important to exclude a substance-induced cause and instead address the substance use disorder prior to making a psychiatric diagnosis of conduct disorder. As with adults, mental illnesses in children are diagnosed based on the signs and symptoms that suggest a particular problem. If symptoms of conduct disorder are present, the doctor may begin an evaluation by performing complete medical and psychiatric histories. A physical examination and laboratory tests, for example, neuroimaging studies, blood tests, may be appropriate if there is concern that a physical illness may be causing these symptoms. Doctors also look for signs of other disorders that may often occur alongside with conduct disorder, such as ADHD and depression. If the doctor can't find a physical cause for the symptoms, they'll likely refer the child to a child and psychiatrist or psychologist, mental health professionals who are specifically trained to diagnose and treat mental illnesses in children and teens. The doctor bases their diagnosis on reports of the child's symptoms and their observation of the child's attitudes and behavior. The doctor will often then rely on reports from the child's parents, teachers, and other adults, because children may withhold information or otherwise have trouble explaining their problems or understanding their own symptoms. Covariation between 2 variables can arise, for instance, if they represent age-specific expressions of similar underlying genetic factors. For example, the tendency to smoke during pregnancy is subject to substantial genetic influence, as is conduct disorder. Thus, the genes that dispose the mother to SDP may also dispose the child to CD following mitotic transmission. Indeed, Rosie L. 2009 found that in mother fetus pairs that aren't genetically related by virtue of in vitro fertilization, no link SDP and later conduct problems arise. Thus, the distinction between causality and correlation is important consideration. How is conduct disorder treated? Treatment for conduct disorder is based on many factors, including the child's age, severity of symptoms, as well as the child's ability to participate in and tolerate specific therapies. Treatment usually consists of a combination of the following: psychotherapy, a type of counseling that's aimed at helping the child to learn, express, and control anger in more appropriate ways. Cognitive behavioral therapy aims to reshape the child's thinking cognition to improve behavioral and behavioral skills, anger management, reasoning skills, and impulse control. Family therapy may be used to help improve family interactions and communication among family members. A specialized therapy technique called parenting management training, PMT, teaches parents ways to positively alter their child's behavior in the house. Medication. Although there is no medication formally approved to treat this disorder, various drugs may be used to treat some of its distressing symptoms, as well as any other mental illnesses that may be present, such as ADHD or major depression. What is the outlook for children with conduct disorder? If your child is displaying symptoms of conduct disorder, it's very important that you seek help from a qualified doctor. A child or teen with conduct disorder is at risk for developing other mental disorders. as an adult if left understood. These include antisocial and other personality disorders, mood or anxiety disorders, as well as substance use disorders. Can this be prevented? Although it may not be possible to prevent conduct disorder, recognizing and acting on the symptoms when they appear can minimize distress to the child and the family and prevent many other problems associated with this condition. In addition, providing a nurturing, supportive, and consistent home environment with a balance of love, discipline, patience may help reduce symptoms, episodes of these disturbing behaviors. Well, this quickly ends about the conduct disorder. Give me the like, thumbs up, comment below, follow me on my social media links. Link is below. Feel free to subscribe if you want to be part of my YouTube family, and if you're down there subscribing, on the bottom right hand corner should be a little notification bell also to turn that on as a key reminder so you can keep up to date with my new content and of what I'm posting on these days. And I'm hoping to do it either like Monday, Wednesday, Friday, but depending, as I said, I'll double check on my schedule. So that's what to do, guys. Thanks for your support, thanks for watching. Do what you love what you do. Until next time, Aspie signing out, and I'll see you again soon. Ciao for now.